Hi, everyone. My name is Emily Chasson, and I am the Regional Director of Atlantic for Ovarian Cancer Canada. So I'm happy to be here today helping facilitate some of the sessions. I hope that you have been enjoying what we have put together for you this weekend. There was so much interest and so many different types of sessions for people to take advantage of. We hope that you've been enjoying it. Just a housekeeping thing off of the top to be sure that you are on mute. And other than that, this session is divided into two speakers. So I'm going to introduce the first speaker, and then when she completes, I'll introduce the second one. And at the end of each of their sessions, we will be able to do a Q&A session. So our first presenter is Dr. Michelle Jacobson. She is a general OB/GYN and menopause specialist at the Women's College and Mount Sinai Hospitals in Toronto. She has a special interest in women who are prematurely menopausal due to cancer therapies and women with hereditary breast and ovarian cancer syndromes. She directs the Familiar Ovarian Cancer Program at Women's College Hospital. Today, her session will focus on the safe management of menopause symptoms and concerns in women who are prematurely menopausal due to risk-reducing surgery in hereditary ovarian cancer syndromes and in women who have actually had ovarian cancer. I fortunately got to see Dr. Jacobson speak last year in Newfoundland, and I thoroughly enjoyed the presentation, and I'm sure that you all will today as well. So welcome, Dr. Michelle Jacobson.
Thank you so much, Emily, for the kind introduction, and thanks to Ovarian Cancer Canada for asking me to speak today. It's my pleasure, and this is a topic that I love talking about. I always say it's very easy to be a specialist or an expert in one very, very small thing, and this is the thing that I know a little bit about. So I look forward to taking your questions afterwards. We're going to talk about menopausal management in women with ovarian cancer and in BRCA mutation carriers. All right, so those are my disclosures. So today we're going to talk a little bit about surgical menopause, to talk about is it safe to take hormone replacement therapy after a diagnosis of ovarian cancer, briefly discuss some treatment options in women who are high risk for breast and ovarian cancer, and briefly touch on some of the other things that you may not have heard as much about, so the genitourinary syndrome of menopause and testosterone use for libido. We'll see if we can get through all of that in 20 minutes and leave 5 minutes for questions. I may race through some of the slides, but I believe they're going to be made available to you. So what are the symptoms of surgical menopause? So surgical menopause is women who go through menopause because their ovaries are removed or because a cyst is removed from the ovary and there's not enough eggs left afterwards. There's a difference between going through menopause with or without a uterus when it comes to treatment. So some women who've had ovarian cancer will have had a full staging surgery with their tubes, ovaries, and uterus removed, among other organs. And women who've had preventive surgery for ovarian cancer prevention may have only had their tubes and ovaries removed, and their menopause management will be a little bit different. But the thing that makes you menopausal is the removal of the ovaries. And we know from studies that are done that women who have their ovaries removed go through a much more abrupt and symptomatic menopause than women who gradually go through a menopause at a more average age in their life. We know that the average age of menopause for Caucasian women is 51 and a half. So women who get a diagnosis of ovarian cancer prior to 50, or women who are having their ovaries removed preventively, maybe as young as 35, may go through menopause 15 years younger than the average age. Most women are aware of symptoms called vasomotor symptoms. Those are hot flashes and night sweats. Women note a decreased quality of life with surgical menopause, both compared to life before menopause and compared to women who go through a gradual natural menopause. And women note a decrease or decline in their sexual health and sexual functioning. Those are the things that people feel. There are lots of other validated symptoms of menopause as well. So we'll go through them here. Perimenopause has irregular vaginal bleeding. Women might get changes in their hot flashes, night sweats, changes in weight gain, but also in weight distribution. So a bit more of a central weight distribution, which you may or may not have noticed. Mood changes, which might be anxiety, irritability, depression, decreased ability to deal with stressors, feeling fatigued or feeling just not right. These are all sort of the common validated symptoms of menopause. And then other women may get joint pains, dry hair, dry skin, breast tenderness, and then changes in the size of the breast once perimenopause is complete. Palpitations, these are all common symptoms of menopause, and I never really write any symptoms off. So if somebody comes to me and says, all of a sudden after my menopause, I started to feel this, is this my menopause? What I found is that women really experience menopause differently, and probably most symptoms you can think of, if that's your experience, then you get to own that. So here we've got the 7 menopausal dwarfs as well, in case you forget what I said. So what about the things that we don't feel, the things that are going on behind the scenes, as I like to call it? So there are negative impacts of premature menopause on long-term health. So women who go through menopause prematurely, before their body was ready, or before really age 45, are at increased risk for cardiovascular disease, for osteoporosis, which is thinning of the bones, and for early Alzheimer's and other cognitive decline. So when it comes to cardiovascular disease, and this is not in specifically women who've had ovarian cancer, but a big study called the Mayo Clinic cohort was followed, and they saw that women who had their ovaries removed surgically before 45 had a significantly increased mortality, so died earlier due to cardiovascular disease. And the risk was about twice as high if no estrogen replacement was used. And if women were able to use estrogen, then actually their risk of dying from cardiovascular disease was lowered than if they didn't use anything at all or had not gone through an earlier menopause. So that tells us that by using estrogen replacement therapy, we're able to mitigate the cardiovascular risk of dying early from early menopause. Women who had their ovaries removed before 45 also had an increased risk of all-cause mortality compared to women who had not had their ovaries removed, also by about 2 times. But interestingly enough, when you compared that to women who were BRCA mutation carriers and had their ovaries removed at 35, they didn't see that those results were replicated. And the conclusion from that study was, and that was a Stephen Narod study out of Women's College, is that because the ovarian cancer risk and possibly some of the breast risk is so high in the BRCA mutation carrier, removing the ovaries gives such an advantage to living longer that it mitigates the risks of the early surgical menopause. So for women who can't take estrogen replacement therapy, possibly because of a breast cancer or because of other contraindications to using estrogen replacement therapy, you can sort of hold tight to the idea that removing the ovaries can still be a life-prolonging event for women who have disease or at increased risk for disease, rather than just as simple as, if I take out my ovaries, I'm going to die younger. What about bones? So these were studies that looked specifically at women who'd had ovarian cancer and were high risk for ovarian cancer. And they found that women who took their ovaries out had a significantly increased risk of bone thinning with osteoporosis, which is low bone density, and that those risks were also ameliorated or improved when estrogen replacement therapy was taken. In terms of cognition, this was not specifically looking at carriers. This is in women who go through surgical menopause before 45, so a significantly increased risk of dementia. And that was something that happened about 25 years after the ovaries were removed. So it's not something that happens right away, although lots of our patients feel like as soon as their ovaries were removed, their brain stopped working. We know that this is something that happens earlier than it would have otherwise and seems to have a temporal or timing relationship to when the ovaries were removed. Again, mitigated by estrogen replacement therapy. And those studies are being repeated specifically in women who have their ovaries removed because of a BRCA mutation. So how are we going to manage your hot flashes? So some women who are either afraid to take hormone replacement therapy or don't want to or can't start with things like lifestyle changes, alternative therapies, traditional hormone therapy, and otherwise non-hormonal but still prescription therapies. We're going to go through all of those options. So women have triggers for hot flashes typically. There tend to be the things that we all enjoy doing. So dietary triggers like coffee, spicy food, alcohol, caffeine, sometimes stressful situations. Having an elevated BMI is a trigger for a lot of women. So women who have a higher body fat have higher rates of hot flashes, and that's sort of contra what you might think, because we know that fat makes estrogen, and women who have more fat should actually probably have more estrogen, and you'd think they would experience less hot flashes, but that doesn't seem to be the case. Cigarette smoking also increases hot flash rates, and there are certain medications that you might be taking that may also give you hot flashes. So SERMs like tamoxifen or raloxifene, some of the antidepressant medications give hot flashes and night sweats, others actually improve them, and a medication called an aromatase inhibitor like letrozole, that would be something women who've had certain kinds of ovarian cancer might take, so a low-grade serous, or women who have had breast cancer might be on an aromatase inhibitor. And this lady's going to the cafe to get her menopause special, which is the cafe mocha vodka Xanax latte to go, which may or may not help her flashes. So what can you do in terms of lifestyle changes? So these are non-medication options for managing your menopause symptoms. Try and determine what your triggers are and try and avoid them if possible. Deep paced breathing has been shown in randomized control trials to improve symptoms. Having a fan, and you can direct the fan directly at you if you share a bed with somebody who doesn't like having the fan blowing on them. I always remind people that there's not actually a rule that you have to share the same blanket with the person that you sleep with. So if you sleep with somebody who likes a heavier blanket and doesn't have problems with temperature control, you can use a lighter one and you don't necessarily have to touch them while you're sleeping or share a blanket. I try and remind my husband of that regularly, despite the fact that I have no hot flashes currently. Taking a cool shower or bath before bed can be helpful. Dressing in layers. So a lot of people find that they're cold when they go to sleep, so they'll put pajamas or socks on, and then they get really hot at night and they end up taking them off at night. So dressing in layers. Dry wicking materials, keeping the thermostat turned down. And you can get cold gel pillows, cold gel mattresses, things that are meant to help keep you a little bit cooler at night. What about the herbals? So people are always wondering about buying things from a naturopath or from a health food store because they've heard that soy, black cohosh, alfalfa, dong quai, ginseng, evening primrose oil, or other sort of all-in-one multi-menosense menopause vitamin products might help with symptoms. I tend to think for the most part with these that if they're helpful for you, then great. You know, there's very little harm apart from the price. People are always asking about taking soy and wondering if they have a contraindication to estrogen. May they be doing damage by taking soy products? And as far as we know, dietary soy or soy products that you take from a health food store don't have enough estrogen in them or the ability to create enough estrogen to cause any problem for people who have contraindications to taking estrogen. So you don't necessarily have to avoid soy products. That being said, this is a chart that shows you the number of vasomotor symptoms, so hot flashes and night sweats per day on the left-hand side, and the bar across the bottom shows time. And what you can see is that hormone therapy is the red line in the bottom, so it drops the the vasomotor symptoms per day significantly. Everything else, so placebo, which is the sort of mustard-colored bar, and the pink is black cohosh, the orange is multi-botanicals, the blue includes soy. What this graph shows you is that none of these botanicals are any better than placebo at reducing the number of hot flashes per day, in contrast to estrogen replacement therapy, which is significant at improving the vasomotor symptoms. And we talked a little bit about the alternative therapies, but cognitive behavioral therapy, so learning how to cope and deal with symptoms when you get them to try and make them go away. Deep breathing or paced breathing techniques, exercise, meditation, and acupuncture have all been shown to be helpful for dealing with these symptoms. What about bioidenticals? So people think or have heard that if they take bioidentical hormone therapy, it's safer than taking more traditional hormone replacement therapy. But I'll bring your attention to this study that looked at about 30 products from 12 different compounding pharmacies, all which were meant to be the same product. And what they found is that a third of them failed the quality control tests that the more traditional pharmaceutical grade hormone therapies were exposed to, and a quarter of them failed the potency standards. So that means that they didn't have the complement of hormones in them that they were supposed to. Now, if they're all too low across the board, they may not be effective, but they wouldn't be that dangerous. The problem is if you're depending on getting some estrogen replacement and your dose is too low, then you're not going to get the benefit for heart, brain, and bone protection. But more importantly, if you still have a uterus, if you don't take an adequate progesterone dose to the amount of estrogen that you're taking, you can actually get uterine cancer. And we see this frequently in women who are taking bioidentical hormone therapy and rub their progesterone therapy through their skin, because progesterone doesn't absorb well through the skin. It absorbs well by mouth or in the vagina, but the estrogen does absorb well through the skin. So you can get an imbalance in the amount of hormone therapy that you're taking if you don't know what you're getting. So what is traditional hormone therapy then? These are standardized dosages of estrogens and progestins. And when we say progestins, we mean a class of medications that looks like progesterone, but may not all be exactly the same as what the chemical progesterone that your own ovary would have made looks like. And these are prescribed to treat symptoms of menopause, like hot flashes, vaginal dryness, everything that we talked about before. They are also effective for the prevention of osteoporosis. So the two clear rules for taking hormone therapy are for the treatment of bothersome vasomotor symptoms or for the prevention of osteoporosis in postmenopausal women. And most women fit into these categories. So lots of different guiding bodies have gotten together: the Society of OBGYNs of Canada, the North American Menopause Society, the International Menopause Society. And the bottom line is that the hormone therapy, which most people are afraid of taking, is the most effective therapy for the treatment of menopausal hot flashes. They work well at reducing frequency and severity, and they also work well at preventing all the other stuff that we talked about. So how do you take hormone therapy? Estrogen can be taken by mouth or through the skin for general symptoms. But if somebody has vaginal symptoms, which we'll talk about in a bit, but mostly dryness, pain with sex, decrease in lubrication, chronic urinary tract infections, abnormal discharge, itching, then the vaginal preparations tend to be more effective and safer because the amount of estrogen that's absorbed from the vagina into the body is really minimal. They tend to just work locally in the vagina where they're applied. What about non-hormonal medical therapy? So this is going to be used for women who have a contraindication to taking hormonal therapy. And typically in this population, that's either going to be a low-grade serous ovarian cancer, for which a woman might be taking an aromatase inhibitor or tamoxifen, or a woman who has actually personally had breast cancer. So women who are high risk for breast cancer but have not had breast cancer, like a BRCA carrier who has previously had a double mastectomy, or who has never been diagnosed with breast cancer, can still take hormone replacement therapy, and that would be recommended for her when she has her ovaries removed at a young age before the average age of menopause. So if a woman cannot take hormone replacement therapy and has bothersome symptoms, then we would use classes of medications like antidepressants. There's a bladder drug called oxybutynin. There are weak blood pressure drugs like clonidine, or neurologic drugs like gabapentin, and you may be familiar with some of these that are indicated for helping with the symptom management, and they improve the hot flashes similarly to a low dose of oral estrogen. So is hormone therapy safe? Because that's really the bottom line here. So for women who have no contraindications, is it okay to take hormone replacement therapy? And we know that when BRCA carriers who were still high risk for breast cancer were studied, what they found is women who had mastectomy, bilateral oophorectomy for prophylaxis, and hormone replacement therapy to age 50 actually gained almost 1 year of life. So that combination in this specific population seems to be good at prolonging life more than if none of the surgeries had been done in the first place. So what if you've had ovarian cancer? And I'm going to specifically talk about epithelial ovarian cancers because this is the most common type of ovarian cancer. Like we addressed, low-grade serous ovarian cancer, women should not take hormone replacement therapy. Estrogen is contraindicated. But in the most common categories of ovarian cancer, we know that quite a significant number of our patients will be premenopausal when they get ovarian cancer. Up to 17% of them may be less than 40 years old. The treatment usually involves surgery, so women will be prematurely menopausal, and the prognosis really changes based on the stage. But regardless of whether you have an early stage disease with a good prognosis or a late stage disease with a poorer prognosis, there are benefits in the respective categories, both with improved mortality, so living longer and preventing other diseases by taking estrogen therapy, or by improving quality of life for what time we have left in a later stage disease with a poorer 5-year survival rate. So I would argue that there are indications to use hormone replacement therapy in both of these categories. Is it safe to use HRT after ovarian cancer? So several studies have looked at this, including 2 large randomized control trials, which is the best type of evidence that we can look at. And what they found is that the overall survival was improved with hormone replacement therapy. So hormone therapy had a favorable impact on women who had had epithelial ovarian cancer. And when a meta-analysis, which means the best studies are looked at and those results are summarized, they found that there was an improvement in disease-free survival and overall overall improvement in disease-free periods from taking hormone replacement therapy. So though we don't use hormone therapy in low-grade serous and granulosa cell tumors, we would recommend it for most types of epithelial ovarian cancer. In endometrioid ovarian cancer, it's a bit of a more controversial area because we know that these can grow in response to estrogen. And even if you've had a hysterectomy, we sometimes use combined hormone replacement therapy in women who've had endometrioid ovarian cancer. So overall, hormone therapy doesn't seem to affect survival in a negative way from epithelial ovarian cancer, but it may actually improve disease-free survival periods. Local therapy inside the vagina is almost always considered to be safe, even if you have contraindications to taking estrogen by mouth or through the skin. What about in BRCA carriers? So there are several studies that have looked at this, many of which have come out of Women's College Hospital. So in 2006, Joanne Katsopoulos published a paper looking at the likelihood of getting ovarian cancer as a BRCA carrier with the ever use of hormone replacement therapy. And she found no increased risk of ovarian cancer in women who had taken hormone replacement therapy. And more importantly, we've looked at women who've had mastectomies and who haven't had mastectomies, but who've had their ovaries removed at a young age. And we found that hormone replacement therapy is safe in those women, regardless of whether it is combined hormone therapy or estrogen therapy alone. Although, just as we expect from all the data that we look at in non-carriers and women who haven't had ovarian cancer, women who take synthetic progestins, Provera, norethindrone acetate, levonorgestrel, had a slightly higher risk of breast cancer compared to the women who were taking estrogen alone or estrogen with progesterone. Unfortunately, in Canada, over the last year, we've had 2 newer medications come to market which don't use any progestin therapy at all. One is called the TSEC, so that's combined equine estrogen with basidoxifene. That's not currently on the market because of a manufacturing problem, but it should be available again second quarter of 2021. And a medication called Tibolone, which has been available in Europe for many years and is now available as a combined pill that gives estrogen, progestogen, and androgen, so testosterone type behavior, by only taking 1 pill a day. So we're briefly going to go on and just talk about what the genitourinary syndrome of menopause is. So that's the urge to go frequently, urination that wakes you from bedtime, or when you put your key in the door, the need to go to the bathroom right away, vaginal dryness, painful sex, recurrent urinary tract infection. And this is something that gets worse the further from menopause you get, as opposed to things like hot flashes and night sweats, which tend to improve in time. And it's related almost completely to a lack of estrogen. So there are lots of different preparations of vaginal estrogen that can be used. There are 2 creams, there's a vaginal tablet and there's a vaginal ring. All of them work similarly, and we're getting a few new compounds to the market as well, hopefully in the next year or so, one of which will be an oral tablet that treats vaginal dryness. That's good for the people who are less comfortable putting anything inside the vagina. And the second is a vaginal DHEA, or a vaginal testosterone type medication that's going to be approved even for women who've had breast cancer. They can be used in combination with systemic hormone replacement therapy. So that means that if you're on a low dose of an estrogen patch or pill that's helping your hot flashes and night sweats, but it's not quite enough to help the vagina, you can still apply some of the local therapies to get that improvement. So the hallmarks of treatment of genitourinary syndrome of menopause are utilize, moisturize, and estrogenize if possible. And we don't consider breast cancer or even low-grade serous ovarian cancer or granulosa cell tumors a contraindication to using any vaginal estrogen. Testosterone therapy is not approved for use in Canada by Health Canada, but there are male products that can be repurposed for use in women. And the International Menopause Society recently came out with a statement where they polled all the different menopause societies around the world and came out with a combined statement dictating the safe use of testosterone therapy in women. This is particularly important for premature menopause, where testosterone still plays an important role, and for sexual functioning. So we do use this as an off-label therapy with close monitoring, knowing that the side effects of using systemic testosterone therapy can be unpleasant, and we don't have a ton of breast safety data. So something to be considered in the hands of somebody with expert experience, but may not be a first-line therapy for most women. So that brings me to the end of my presentation, and I'd be happy to take questions that were sent in ahead of time or through the question and answer period.
Hi again. There's 2 questions that came in. First one is, I was diagnosed after menopause and still have some hot flashes. So is the risk lowered for osteoporosis, cognitive issues, etc.?
So the good news is yes, when you go through menopause at an average age and then have your ovaries removed postmenopausally, the later from your menopause, the better the prognosis is from a bone and a cognitive point of view. But in general, women who are already after menopause who have their ovaries removed don't need to worry about the risks of premature menopause and all those things that we talked about today.
Okay. Second question. My oncologists think the opposite regarding taking hormones, which leaves me having huge menopausal symptoms at age 41. I am begging for help. My hot flashes are horrible. No sexual life at all. Please help. Suggestions.
So certainly, there are more and more very specialized clinics coming up. And if you are located near to me, I would be very, very happy to see you and talk about this. We have frequent disagreements with oncology because people who are maybe not as well versed in the menopause literature, but are very, very well versed in what can happen with bad cancer treatment, are afraid of using hormone replacement therapy, and they may discount the importance of quality of life once they've achieved what's so important for survival. And it is a constant give and take, but in a situation like that where your quality of life is so poor, everything is a risk and benefit analysis. So I think seeing somebody with some comfort and expertise and making your own risk benefit decision is important in individualized therapy.
And there's a sort of second part to that. The same person said, I found out that what makes me not have hot flashes is a warm sun environment. Does that make sense?
I mean, like I said, I think everyone's menopause is personal, and maybe when you're in a warm sun environment, you have less stress, you have a better mood, you relax more. If you're living in Canada, we certainly can't get a warm sun environment in most places most of the time. So we have to figure out ways to cope with the situation that we're living in. So I think we have to find what works for you. And it's not always going to be a straightforward decision.
Okay, and one more question. You said this in your talk, but just to be absolutely clear, women with low-grade serous ovarian cancer can, capitalized, use vaginal estrogen. Can you give an example of brand names, what to buy, etc.?
So the vaginal estrogens in Canada are all prescribed. So the creams that are available are conjugated equine estrogen cream, so Premarin cream, or estrone, which is estragyne cream. There is Vagifem, which is the vaginal tablet. And there's the E-string, which is the vaginal ring that gets inserted and changed once every 3 months. Again, always check with your oncologist, but if you haven't had vaginal recurrences of low-grade serous and your vaginal symptoms are worse, it should technically be safe to take vaginal estrogen. We use this in women who've had breast cancer and are on aromatase inhibitors all the time, which is a similar type scenario.
Another question. In patients with HGSOC, that is ER and PR positive, can they use vaginal estrogen?
So vaginal estrogen, absolutely. And the estrogen receptor status of a high-grade ovarian cancer was taken into account in those randomized control trials looking at women who've had high-grade serous ovarian cancer. And even in women with ER-positive disease, taking systemic estrogen replacement therapy did not worsen survival or recurrence rate. So both systemic and vaginal estrogen should be safe in almost all high-grade serous ovarian cancer.
Okay, I'm going to read you 2 more questions in keeping things on time. So the second last one is, so if you have a genetic mutation that puts you at a greater risk of breast cancer, i.e. ATM, but you are worried about your long-term risk of not having estrogen, how do you weigh the risks of taking versus not taking hormone replacement therapy?
So our highest genetic risk patients are our BRCA 1 and 2 patients when it comes to breast cancer risk. The ATM risk doesn't confer even the same high rate of breast cancer as a BRCA gene mutation. And we know that in this population of women who's been studied, taking hormone replacement therapy does not increase the risk for breast cancer. So if you are prematurely menopausal specifically, or just really suffering from symptoms, you carry the ATM genetic mutation, you still have your breasts, let's say, and you're doing breast screening, that would not be a contraindication to taking hormone replacement therapy. And in fact, your overall survival is likely better from taking hormone therapy. That being said, we would always choose hormone therapy that is the most breast friendly. So in a situation like that, the TSAC, which is Duaviv, or cyclic estradiol replacement with progesterone only about 12 days a month, those are going to be the better options than taking a synthetic progestin regularly.
Okay. And the last question, my ovaries were taken out when I was 35. I am definitely feeling cognitive challenges. Can anything be done to claw back any of what I worry I've lost? My short-term memory is horrible now, and it used to be a strength. Help? Question mark.
That's so hard. I sympathize and empathize. I find that the women who exercise their brains as much as possible tend to have the best outcomes. So whatever it is that works well for you, crossword puzzles, Sudoku, making lists, those kinds of things that help with your short-term recall can definitely be helpful. There's some evidence for taking medications like Vyvanse, which is a stimulant medication, to help with cognition in menopause. But for women who have sleep dysfunction, I find that they can often be a bit contradictory to one another. So I would say figuring out a way to live with the new normal is important so you can still function well, but also exercising your brain as much as possible to try and regain some of that cognitive change is also, in my experience, helpful. That's not published in any paper.
You know what? There's actually only one more question, so I think we can do it versus cutting off. So this person says, I cannot take hormone replacement therapy by recommendation of my oncologist. I am on antidepressant therapy. Would taking the soy or black cohosh be okay to take as well? I know it may not have great results, but anything may help. I was diagnosed at age 46, only had some hot flashes before surgery and treatment. They increased after. My mood worsened. What's the impact of HRT / estrogen on mood?
So,
sorry, that's two separate people. They had almost the same first name, and I apologize. The first one is the soy black cohosh. Could they take that?
So can you take it? Absolutely. May it work, maybe as well as placebo, which can sometimes be 30 to 40% effective. So no harm. That being said, also, I think see a menopause specialist, talk to one, determine if it is potentially safe to take hormone replacement therapy, because I can't take hormones is a blanket statement that is often not really supported by evidence. And then the second question was mood being on an antidepressant.
Hormone replacement or estrogen on mood.
So the North American Menopause Society recommends taking estrogen therapy for the treatment of peri and postmenopausal mood symptoms as sort of a third indication beyond just the treatment of hot flashes and prevention of osteoporosis. So we know that estrogen therapy certainly does improve mood. Some of the SSRIs and SNRIs are better at treating hot flashes and night sweats than others. So I always find optimizing the mood pill that you're on to try and get a double whammy of treatment is helpful. But also you could consider taking estrogen therapy if you don't have any contraindications for mood with good results.
Awesome. Okay, great. We got through all the questions, so that's great. Thank you so much, Dr. Jacobson. There was lots of information in your presentation that I'm sure everybody who's watching learned something that's applicable to themselves or someone they know. So thank you very much. Now I'm going to introduce our second speaker. Cameras on there. Okay. So Dr. Anne Katz is a certified sexuality counselor and clinical nurse specialist at Cancer Care Manitoba in Winnipeg. Dr. Katz is the immediate past editor of the Oncology Nursing Forum, the premier research journal of the Oncology Nursing Society. She was inducted into the American Academy of Nursing in 2014. She is the author of 13 books for healthcare providers and healthcare consumers on the topics of illness and sexuality, as well as cancer survivorship. Her latest book, the second edition of Women, Cancer, Sex, will be published in late 2020. In the brief session, Dr. Katz will highlight the importance of communication with your partner and healthcare providers. Being diagnosed and treated for ovarian cancer presents many challenges to women, and these will be discussed along with strategies to address them. So welcome, Dr. Katz, and you can start your presentation.
Thank you so much. So I'm happy to be here on a cold Winnipeg morning. Well, it's almost afternoon now. So I think my presentation is quite a nice juxtaposition to that of Dr. Jacobson, because I'm going to be talking about the more psychosocial aspects of changes that happen with ovarian cancer. So I'm going to focus today on communication, sexual changes, but from a slightly different perspective, and the importance of touch and connection. So, I hear this often in my office as a sexuality counselor, and perhaps some of you have thought about this as well. So, I'm scared my husband's going to leave me. We haven't had sex since treatment. And frankly, I wouldn't blame him. So really, a lot of this is about communication. So we make assumptions about what our partner is thinking and feeling, and they do the same for us. And I think we get it wrong about 90% of the time. I know I do in my own relationship. And, when a relationship is fraught with the stress that goes along with a cancer diagnosis and cancer treatment, the fear of recurrence that goes with that, anxiety, depression, etc., and all the changes that have happened for women, we often really do assume that, our partner is going to leave, or he's not interested, or she's not interested for that matter. So it's just so important to talk to your partner. And it's not necessarily an easy thing to do, because we are often afraid of hurting his or her feelings, and it goes the other way as well. And I think often there really is a lack of understanding on the partner's part about just how deeply this experience goes for women. And it's not just about the diagnosis of cancer. It's not just about the treatment. It's also about, the number of invasive pelvic exams, what feels like, the world and its dog, looking at very, very private parts of you. And just yesterday, I was actually having a conversation with a patient on the phone because of COVID. I would much prefer to have been in the same room as her. And, she was saying that this having these repeated examinations, and sometimes more than one examination at an appointment, because there's a resident or a fellow and then the attending, and women tend to dissociate, so they really disconnect from their body as a way of getting through this. So this, there's so much going on. There's fear of pain, because the last time perhaps you attempted to any kind of sexual activity with a partner, it really hurt. And pain is biblical in that pain begets pain begets pain. So in anticipation of pain, everything in your body tightens up, and that includes the pelvic floor. And so the next time something's attempted, that pelvic floor as a coping mechanism really tenses up. And it really lands up in a whole body, whole person issue. Women often feel really guilty that they're not able to be sexual with their partner in sort of the traditional way we see being sexual as having sexual intercourse. So there's guilt there, and certainly grief, both for the woman and her partner and the couple as a whole. Grief for what has been lost, for what was spontaneous and pleasurable and fun and a way to connect and a way to get over conflict is now none of the above. So it's so important to talk about this. Don't talk about this in the bedroom. Talk about this in a neutral place, fully clothed. And some people really do need help to talk about it, and I'm going to talk in a little bit about this. What about finding help? So, I often hear from somebody, where can I find information about what is normal for someone like me? Women often say to me, this is what I'm going through. Have you ever heard anyone else going through this? So this is not something, these sexual and relationship changes that are often talked about. So how do you talk about this to your healthcare provider? Unfortunately, and this is something that I personally am trying to change by educating oncology care providers and other healthcare providers, oncology care providers or healthcare providers tend not to raise the topic because they're scared of offending the patient, kind of, asking questions about something that's very, very private. They say that they don't have enough time in the day to talk about this. And the patient or the woman doesn't want to talk about it either, because if it was important, the healthcare provider would have talked about it. And the result is this deafening silence. And we know that what women want is information that provides them with some anticipatory guidance about what to expect, so that they don't feel alone, they don't feel isolated, they don't feel that they're the only person in the whole wide world that this has ever happened to. And then, of course, we come to the whole issue of sex. And by sex, I mean a vast array of activities, not just sexual intercourse. But, sexual changes are extremely common in terms of desire, in terms of arousal, in terms of orgasm, in terms of sexual satisfaction. Those will all change for many women after treatment, both for physical reasons, so anatomical reasons where there's perhaps internal scar tissue. It'll change for emotional or psychological issues with that fear of recurrence. Women with gynecologic cancer often say that they're afraid that being sexual will somehow cause a recurrence or make things worse for them. So what are some of the changes that we see beyond those genitourinary symptoms that Dr. Jacobson talked about? Certainly, body image is a huge, huge issue for women and for men, actually, which many people don't know. But for women who've had surgery, there's often, a great big scar. I think that women who land up with a good-looking scar, which fades over time, really are the exceptions. Women often land up with huge scars that look like a railway track over their tummy. So scarring is a big issue. Externally, weight gain. Hair loss. And one of the things that I always talk to my nursing colleagues about is, when you talk about hair loss because of chemotherapy, do you think you could talk about pubic hair loss as well? And now I know that there are women who pay, $60, $70 to get pubic hair ripped out by its roots with hot wax. You can perhaps hear my bias about this. But we don't often warn women that their pubic hair is going to fall out when the hair on their head falls out, and their eyelashes and their eyebrows. And some women actually don't mind this, but there are other women who really do, and they say that they feel like they're a little girl. So the whole idea of being sexual with no pubic hair, just feels really, really weird. Certainly with vaginal and vulval dryness, and I always stress that the vulva is involved as well. If you follow me on Twitter, you will know that when somebody tweets something about the vagina, what they often mean is the vulva. It's the outside parts, and those can be dry as well. So sexual touch can be really, really painful. And certainly, we see the decreased sensation of orgasm, decreased frequency of orgasm, which then leads for some women to decreased sexual satisfaction. So, really can be just a whole host of symptoms that really change everything for women. And I just want to talk, a little bit about the loss of desire that many women feel. And desire or libido, first of all, it's not sort of one thing that happens. It's really a whole spectrum of things. But we recognize now that for many women, desire is something that is reactive. It's not spontaneous. So You know, if you think back perhaps to the beginning of your primary relationship, you know, that period of time where you can't get enough of the other person, you think about them constantly, you're kind of always ready to go. That changes with time, and I think it has to, because, you know, life gets in the way. But we often long for those days, and we often think that that is how we should feel all the time. So that spontaneous desire needs to be there, and if it's not there, sexual activity of any kind is not going to happen. We now recognize, and most of the work on this topic has been done by Dr. Rosemary Besson from UBC. We now recognize that for many women, cancer or no cancer, desire is actually reactive. So it occurs in response to arousal, to feeling turned on, which hopefully will happen when you start the kissing and canoodling part. I never say foreplay, because foreplay to me means something comes afterwards, right? It's before. And sometimes kissing and canoodling is all that you can do. And I'm going to talk more about that in a minute. So Dr. Besson has shown that for many women, desire is reactive and not spontaneous. So if you're in a relationship where you can say, no, I'm not feeling anything, let's stop, you know, and get a cup of tea. If you're in a relationship where it's safe to do that, there are not negative consequences from that. It's important to, you know, do the kissing and the cuddling and stuff. And often that is when women start to feel that reactive desire. You know, so if intercourse, which, you know, let's face it, many people find is really the way that they express love, affection, get over arguments, etc. And I'm often fascinated by how intercourse is like the holy grail, right? That's the way people think about being sexual. And there's a whole lot of other stuff beside which you can do. So, you know, if intercourse is not happening, what on earth can we do? Well, there's a whole bunch of stuff that you can do. The first thing I want to talk about is communicating with your partner about what is okay. And, you know, in many ways, we communicate like with our partner about these kinds of things, like dolphins and whales, with grunts and squeaks. And over the years, you learn to know what those grunts and squeaks mean. Unfortunately, or fortunately, when you're having problems, you actually have to use your words to talk about this. So telling your partner what feels good, what doesn't feel good. And I know that for many people, it just feels really strange to be talking about this. You know, some of us don't even know the correct anatomical parts. And, you know, we say down there, or a little bit to the left, a little bit to the right. That's communicating. We know that those of us who work as sexuality counselors or sex therapists, that sensate focus exercises, which were developed by Masters and Johnson back in the 1950s and into the 1960s, are a really great way for couples to connect again. They're a series of exercises that you do that for the first 4 or 6 weeks, intercourse is completely off the table. And it's a way of connecting with yourself in terms of touch as something pleasurable and not something painful. It's a way of connecting with your partner without that pressure that, oh my goodness, you know, he's going to want to have penetrative intercourse and I don't want to, and the last time it really hurt. So sensate focus has been shown to be really, really effective, but it takes patience, it takes practice, and it's really important to be really aware of not going further in the moment than you're supposed to, because there's a reason why these are exercises. Certainly counseling, really, really important. Sexuality counseling or sex therapy is about talking about things. It's about a professional asking questions and allowing you and your partner to talk. And I really stress that couples counseling is so important, because something happens in the room when you have a couple and a professional person. And sometimes back in the day when I was seeing people in my office, There were times where, honestly, I would ask a couple questions. The couple would start talking to each other, and I'd be thinking, do you think I can check my email? Maybe go get a cup of coffee. Obviously, I didn't either, but it really is quite magical how that happens. So counseling, really, really helpful. Bibliotherapy, which is a fancy way of reading. There are many, many books out there, and I'm going to do a little bit of shameful self-promotion in a little bit. There are many books out there that can help, that you can read with your partner or give your partner to read, which can help starting a conversation. We know that physical activity is really, really helpful in promoting sexual health. And I think it's really important to get some physical activity with your partner. A walk, for example, right? You're watching where you're going. You're not making eye contact. So sometimes it's easier to talk about these sensitive topics when you're not staring at somebody in the face. And then there is the whole issue of non-sexual touch. Touch is so important. Touch is the first sense that we develop. So, you know, babies who stick their finger or their thumb into their mouth, that's touch. Babies who like to hold on to their blankie, that's about touch, right? Babies who twirl their hair or sometimes stroke their own cheek, that is touch. It is the first language that we learn, and it is so important. You know, we can live without sex, and many of us do. We cannot live without touch. And people who do not experience touch, and we're certainly seeing it today in the time of COVID, right, where we can't hug a friend anymore, we can't shake a hand in greeting, that without touch, we get skin hunger, we become irritable, perhaps aggressive, a little bit detached, and even depressed. So touch is so important. And I find often when sex has gone away or sex is too painful or people don't know how to approach it, they also stop touching. And, you know, women will often say to me, but if I touch my partner, he or she thinks that I'm initiating. And in reality, you know, this is where your grown-up words come into place. I need a hug, or I want to hold your hand, but that's all I want, right? It doesn't mean I want anything more. I just need to touch and be touched. Touch produces oxytocin. Oxytocin is the hormone of attachment. It is the hormone that women have a lot after they've had a baby, because we have to love that baby because we don't understand what they want from us. And I am convinced that, you know, without oxytocin, we'd be pitching those babies out of the window because it's frustrating and we don't know what they want. So touch, oxytocin, connection, so important. Finally, you know, if you want to get hold of me, feel free to email me. That's my email address. I don't mind being emailed if you have a question. I have a website. I also have a small private practice right now. I'm on Twitter at drannekatz.com. And on the left of your screen, this is the Shameful Self-Promotion, the second edition of my book, For Women, About Women, Woman, Cancer, Sex, is coming out, I just heard this week, on November the 30th. So watch for it on all your web-based booksellers, etc. The first edition of this was an award-winning issue. I'm really, really proud of it. I hope you will like it. So I am now going to wait to see if there are any questions. And I think I have to stop sharing.
Yep. So Dr. Katz, there isn't any direct questions. However, there are lots of comments, very positive. So I'm just going to read a few to you. This session feels so important. Thank you for including this. Good to know others feel the same way. Another one, I have never thought about the effect of being poked and prodded. You have it. So many people have been poked and prodded in what was a very private area. And then someone else said, I used to be super athletic and proud of my body at 67. Nobody seems to understand how difficult it is to cope with my new non-athletic body. So there's been lots of positive comments, and there may have been some more come in since then too. But I think it's been very well received. Obviously, menopause as well. I mean, one of the big things that we do at Ovarian Cancer Canada is try to normalize conversations about ovarian cancer. And then within ovarian cancer, there's lots of topics that are still a bit taboo. And this being one, and menopause as well, that women don't talk so openly about issues that they have. So the more we talk about it, the more normal it comes, and then people don't feel alone, because that's one of our big taglines is, you know, we're by your side, you're not alone. So I really appreciate you offering this today, and I'm sure everybody on the screen right now as well reiterates what I'm saying. So.
Yeah, and I'm seeing, you know, I just, sorry to interrupt you, I'm seeing all these comments, and I really am so grateful. And honestly, if I've helped just one of you to either have the conversation or to not feel so alone, you know, obviously this is a topic that I'm immersed in, and whenever I'm writing books, which I'm actually just writing another book now, I can't seem to stop myself. I think this one will be number 15 or number 16. And I actually remember after, I think, number 1 saying, oh, I'm never going to do this again. And here we go. But, you know, so I'm immersed in the professional literature about it. And one of the unique things about ovarian cancer is that because many women are diagnosed so late in the disease, there is this assumption on the part of healthcare providers that they're too sick for sex. And, you know, that is just so wrong because, you know, first of all, you know, even at the end of life for many people, men and women, touch is so important. And it's not just about penetrative intercourse, right? It's about all the other stuff that makes us feel whole and is such a comfort. And it might be about masturbation, which helps you fall asleep and doesn't make you grow hair on the palm of your hands, as my grandmother told me. So, you know, self-touch is also important. It feels good. It's comforting. So it really bothers me that there really is little research into this period, and little into this the phenomena that women go through, particularly women with ovarian cancer. I see there's just another question. There's a question here from Jennifer. When is my new book available? The exact release date? November the 30th. I mean, it couldn't have been the 29th, right, or the 26th, but November the 30th. But what often happens with these publishers is that it's available for pre-order on, you know, Amazon and those kinds of things. So I believe it's going to be available in paperback, which is important in terms of cost. I'm really proud of it. It's a complete rewrite from the first edition. You know, I've learned a lot from the patients that I see. So thank all of you out there, those who I've seen professionally and those that I haven't, of just helping me learn more and more every day.
Yeah, I know something I think about in my job and, you know, with women that I've met or even in my own personal life. Like, I often think of women who are single and going through cancer, not just the sexuality side of it, but just that, like somebody giving you a hug or you know, giving you some affirmation through touch. Yeah. That I think that it must be a very lonely thing to experience as a single person.
Yeah, and I think especially now where, you know, your friends can't even hug you.
Yeah.
Right. And, you know, I certainly miss seeing people in person in my office, because sometimes I can just lean across and put my hand on somebody's knee or on somebody's shoulder. And, you know, it means so much. And it means a lot to me when somebody says to me, can I give you a hug after we've had a session? And I'm not really a huggy person, but, you know, when that happens, man, you know, up goes that oxytocin and I'm good for the day.
Yes. Well, in trying to keep on schedule here, I'm going to cut off this session.